In this session, we'll begin the discussion about the three major ascending and descending pathways in the central nervous system. We'll start off with the corticospinal tract, motor pathway, which you've already encountered, and we'll just fill in some of the gaps, so we'll move quickly through that. And then the next session will be the dorsal column medial lemniscal pathway, which is a sensory pathway. Third will be the spinal thalamic system, a sensory pathway for pain and temperature. And then there'll be a fourth that combines all of these pathways together. And you can review each of these separately. We'll look at first the corticospinal tract, the motor pathway. In this series, we'll be examining the pathway at every level of the central nervous system, from the brain, brainstem, and spinal cord, both for the corticospinal pathway, the dorsal column lemniscal pathway, as well as the spinal thalamic tract. And then we'll be looking at the effect of lesions at each of those locations and the signs and symptoms associated with each damage at each of those. We'll start off with the corticospinal tract. Recognize that the corticospinal tract originates in the precentral gyrus and is responsible for precise voluntary movements. The corticospinal tract mainly innervates flexomusculature of distal extremities, and damage to that pathway produces a weakness of voluntary movement, spasticity, and hyperactive reflexes. The pathway starts out in the cortex in the precentral gyrus, with the foot represented medially in the precentral gyrus portion of the paracentral lobule, or the paracentral gyrus. The trunk is represented at the vertex, the arm more laterally, the hand further laterally, and as we'll see, the face most laterally. It is a two-neuron chain. This upper motor neuron travels from the cortex all the way down to the lower motor neuron, and the upper motor neurons descend through the central nervous system, and before they decussate at the pontomedullary junction. As we can see, the fibers, starting out in the cortex in the precentral gyrus travel through the corona radiata and the internal capsule into the crus cerebri in the midbrain, on into the pons, and then into the pyramids at the medulla, and then cross over on to the other side and travel in the lateral funiculus of the spinal cord. The blood supply we can see at this location, and that is the posterior cerebral artery, feeds the midbrain, the crus cerebri, and the anterior spinal artery feeds the medulla, and we can see that the anterior spinal artery also feeds the corticospinal tract in the spinal cord. Those fibers come down in the corticospinal tract and then peel off at different levels to activate excitatory way flexor motor neurons to flexor muscles, and tend to inhibit by interneurons extensor muscles. We see here again the blood supply to the midbrain at the posterior cerebral artery. The basilar artery supplies the pons, corticospinal tract, and the anterior spinal artery supplies the pyramids. The anterior spinal artery also supplies the corticospinal tract in the spinal. We can see here the pathway coming down from the cerebral cortex through midbrain, pons, and medulla on the same side, crosses over at the pontomedullary junction to the other side, to the lateral corticospinal tract, and then eventually will synapse at ventral horn or lower motor neurons at various levels of the spinal. We see here those pathways, and this emphasizes the corticobulbar fibers that start out on the lateral portion of the precentral gyrus and then join the corticospinal tract at the internal capsule. As fibers come into the midbrain, they occupy the middle portion of the crus cerebri, and the corticobulbar fibers, represented by H for head, arm, and leg, corticobulbar fibers a little bit medial to the corticospinal fibers. As we go lower in the midbrain, we see the corticospinal fibers in the same location in the crus cerebri, in the middle third of the crus cerebri. As we come into the pons, the fibers are dispersed partially by the crossing cerebellar fibers, but we see the corticospinal fibers again in this position near the midline. As we come into the medulla, we see that the corticospinal tract is concentrated in the pyramid on one side, just below the olive and just below the medial lemniscus. As we come to the spinal medullary junction, the fibers in the pyramid travel over to the other side and will occupy a lateral position in the spinal cord. And from the spinal cord, they'll travel in this lateral position until they reach their destination on the lower motor neuron, which will activate the muscle. Lesions to the corticospinal pathway at the upper motor neuron site, either in the motor cortex, in the internal capsule, the brainstem, or the spinal cord. All of those can produce upper motor neuron lesions. The patient would present acutely with spinal shock, with flaccid paralysis, hypotonia, and hyporeflexia. And then chronically, we will see spastic paralysis or paresis, and hyperreflexia, increased reflexes, increased deep tendon reflexes, such as the knee jerk. And we may see contractures and spasticity associated with that hyperreflexive state. That spasticity is a very strong resistance to passive movement. And there'll also be increased tone in the muscle and a Babinski sign, that is with an upgoing toe. There may also be disuse atrophy over time, but it is milder compared to lower motor neuron lesions in general. This is an indication of the upward going toe seen with the Babinski sign, and the posture that may be assumed following corticospinal damage to upper motor neurons in the brain, and that is a facial paralysis, a flexed arm, and an extended leg. The geometry of the pathway dictates where the effect will be. So if there's spinal cord lesions, caudal to or below the spinal medullary junction, there will be ipsilateral upper motor neuron signs below the level of the lesion. And the effect will depend on which parts of the body, based on exactly what level. That is, if it were at the thoracic level, then it would affect motor neurons below the thoracic level, sparing the arm, but affecting the leg. Above the spinal medullary junction, that is in the brainstem, internal capsule, and motor cortex, corticospinal damage will result in contralateral signs and symptoms. Those effects are summarized here, where if there's damage in upper motor neurons in the brain or brainstem, there'd be spastic paresis, paralysis, contralateral, and below the lesion. If there's damage in the spinal cord, there'll be spastic weakness, ipsilateral, and below the lesion. At the site of damage, there would be flaccid paralysis, ipsilateral, at the level of the lesion. Lower motor neuron lesions, that is at the ventral horn cell or at the axon of the lower motor neuron, or at cranial nerve motor neurons, produce acute paralysis, that is, there's no activation of muscle fibers, hypotonia, hyporeflexia, fasciculations, and fibrillations seen in the EMG. The fasciculations are actually visible movement of contractures beneath the skin, while the fibrillation depends on electrical recording of discharges of muscle fibers. Chronically, there will be a similar appearance of flaccid paralysis, hypotonia, hyporeflexia, and then very severe atrophy. It's a denervation atrophy. And examples of this include poliomyelitis, which destroys anterior horn cells, and Guillain-Barré, a demyelinating disease of the peripheral nervous system.